Think there we go. All right. Thank you, Melissa. And so we always like to start off our action period calls by showing you all the key driver diagram, just because everything that we do originates from our drivers. So today action period call, we're focusing on three specific drivers, which is the standardization of screening and diagnostic protocols, referrals, as well as continuous quality improvement. So, our first clinical presentation today is going to be more of a discussion about mental health screener workflow, and it will be facilitated by Doctors Christian and Panchal. We have Dr. Christian, who is a clinical health psychologist in the Department of Psychiatry and Behavioral Health in the Institute of Behavioral Medicine Research, Ohio State University College of Medicine. She has experience in topics such as behavioral medicine and pregnancy, with an emphasis on effects of psychological stress on immune function. And then we also have Dr. Panchal, who is a primary care physician at The Ohio State University Wexner Medical Center, who specializes in women's health. She is an instructor on advanced life support and obstetrics. She's been an associate professor, program director for the family medicine residency program at Ohio State, as well as director of maternity and women's health, as well as associate professor. So thank you both for joining us here today, and please take it away.
Okay, thanks so much. I think I'll get started. And apologies, I'm calling in on my phone because I was having some technical difficulties with the microphone on my work computer, but I think I can make this work. So today we're going to be talking about some things about standardizing workflow, and hopefully this can be an interactive discussion about what is currently working at different sites, how you came to that decision process, if there are any pieces that you feel like perhaps aren't working or could be working better, and just to also get feedback from other sites to see how they're doing things, which might inform your processes. So first of all, we'll talk about the current state of the mental health screeners, including which screeners are being used, who is administering those. Are these self-administered or administered by staff? How are the results documented and communicated? And how are the positive screens addressed and monitored? So hopefully closing that loop and moving along from gathering that information to using that information and then being sure there's a follow-up occurring. And we'll have some interactive questions here to start. I'm going to go to the next slide. Okay, so first, the first question is, who is administering the screeners? And if you could answer this question, I don't see a poll popping up, but perhaps that's popping up if you're not on an iPhone.
Do you see it now?
Let's see. Oh, it gives me an option to view. Okay.
I can see it on my end.
Yes, I can.
Oh, you can? Okay. Maybe I can log. Let me see if I can log into Teams as well on my computer and just stay muted. Oh, I can see it here in the Teams chat on my computer. Okay, so far we have, oh, the responses are still coming in. Okay, I can see them here. And how many people should we expect responses from today? Just so I know how long to wait for the responses to come in.
Probably give it just a minute and then kind of keep going.
Okay. Okay, so far we have 7 responses, with 3 being that it's administered by nursing staff or a medical assistant, 2 being self-administered, and 2 being other. And there's still some responses coming in. For those of you who responded other, would you mind turning off mute and describing what the other processes are that you're using?
Hi, this is Lauren from Total Health. I'm not sure if my mic is working. Can anybody hear me?
Yep, we can hear.
Okay. So I kind of sent it in the chat as well. We typically will send questionnaires to new patients via MyChart if they have MyChart available ahead of time. Also before mood recheck appointments. We also will have patients self-administer if that wasn't an option for them or they didn't get to it. And then the providers typically will administer if our patients are non-English speaking, because we don't have any all of the screeners are English only. In our clinic or in
Oh,
QHC, we have lots of non-English speaking patients.
okay. So you have a lot of flexibility and adaptability depending on the situation. Do you feel like in a situation those anyone falls through the cracks, or do you feel like there's a good system in place for those different methods?
I worry sometimes when we are administering the screening with interpreters, worrying that things are getting
Mhm.
lost in translation. I had a patient yesterday who speaks Swahili, and we were using interpreter services. And you have no control over, you don't really know how the interpreter is presenting things either. And there seemed like there
Mhm.
was a disconnect in the conversation between what I was asking and then some of the answers that I was getting from the patient.
Interesting. Okay, and we don't even have a poll question specific to that, so I'm glad that that came up in this context. Okay, so it looks like probably all the responses are in terms of right now we have 50% saying they're being administered by staff, 25% self-administered, and then we have the two of the other responses. Okay, let's go on to the next poll question. And when are the screeners administered? During check-in, during rooming, during the visit, or at another time period? Okay, it looks like it's pretty evenly split between check-in and rooming, and I'm guessing that some of that other response might be through my chart even before they arrive or arrive for check-in. For those of you who are using either a period at check-in or at rooming, can someone turn off their mic and comment on how that's working for you, how you selected that timing, if you've ever considered a different timing? How about if we start with one of the three people who selected during check-in? How does that work for you, and how did you select that timing? Okay, so people must not be available to unmute right now, which is okay. How about anybody who's selecting during rooming and how that timing is working for you? Okay, well, we can go on to the next question, and if questions come up with about this topic later, we can come back around to this. So let's go on to the next poll question. Okay, so how are screeners administered? Do you use electronic, paper, verbally, provided by a provider, or some other method? Okay, so far it looks like we have electronic and a couple of paper submissions. For those of you who are using paper, if you're able to unmute, could you comment on how that information gets into the medical record?
So, in the instances where we use paper, the
Mhm.
providers, basically the MAs, are giving the screening. We have laminated copies, and then we use dry erase, and we can just clean it between
Mm,
patients. Um, they fill it out. They give the patients the screener during the rooming. When the provider comes in the room, we then enter in the answers from the screening.
okay. Okay. All right. And let's go on to the next poll question. Is there a workflow in place for mental health screeners during telehealth visits? So these have become more common and could be a place where people fall through the cracks. Okay, so far we have some no's and some others. Again, if people want to comment on what the other means in this context, that would be helpful. I'm not sure if that's a do not know or what that response refers to.
Hi, this is Natalie from Freeport Family Health Center. We marked other because we aren't doing telehealth right now, so.
Oh, okay, well, that helps clarify. That makes sense. That makes sense. Okay, so telehealth might be a place where, at least for those providing it, where the mental health screeners might not be being standardly applied right now. Okay, and I believe there's one more poll question. Is that right? Oh, nope, that was the last one. Okay, so I think Dr. Panchal now is going to talk about some information from the literature about best practices for applying these, and then we'll bring the conversation back to the group.
Yeah, thank you, Dr. Christian. So it sounds like we are all doing multiple things, which is very common in family medicine, primary care settings. We have to be flexible with our patient population. But studies have shown that patients can successfully fill out these mental health screeners on their own, and they don't always need our assistance. But if we do administer it verbally, it is crucial that the administrator asks the question to the patient exactly as it is written on the form to ensure accurate data. So we could see where there are some limitations when there's an interpreter involved, which obviously we just need to come up with some better tools in those situations. And we don't always need to rely on the provider to do these. So staff can be trained on how to correctly deliver these screeners. And in cases where patients have difficulty with reading or comprehension, a staff member can assist the patient in completing the tool. Assistance with completing the tools can be provided by any level of staff, whether they're checking them in or rooming them. And as long as they've been trained in understanding the purpose and the importance of the screener tools and strategies for engagement and completion of the screeners. I'm ready for the next slide. Great. Another study showed that compared with verbal screening, self-administered screening, so the ones that we get on the tablet or they're sent before the actual clinic visit or even after, that they actually detected more than twice as many patients with concerns that could warrant immediate clinical attention. And prior studies to this have shown that patients feel that these tablet-based screeners is more private than the face-to-face screening, and therefore they're more likely to disclose more sensitive information. And obviously, limitations to the verbal screening include the potential of paraphrasing the screening items that we're asking them in a leading fashion. Thus, it's very important to ask these questions specifically and exactly as they're worded on the screener. Next slide. So we're back to a poll question again. This time I get to give it. So how are screener results communicated? Do you give them verbally or do you send them a written communication? Or does the EHR send kind of an alert or reminder? And these are results to the provider themselves. Are there any, and you guys can put it in the chat if you want, if you aren't able to unmute. But if anyone wants to share any challenges or successes that they've had with any particular method that you're using.
I think when patients are able to complete the questionnaires electronically prior to their appointment, that's really helpful because as the provider, it comes straight to us. I can see ahead of time if there's something positive, and that kind of helps me frame the visit going in. Sometimes when I'm going into the room and then I'm looking at their sheet after, I'll address it, in the moment as I'm, entering everything in. I see, your score was this. I'd like to talk to you a little bit more about that. And then with the ones where it's like the translating ones, those ones tend to be the most difficult, but yeah.
Yeah, absolutely. Agreed on that one for sure with my own experience. Anyone else want to share any other challenges that you might be finding? Not all EHRs are the same. Some are easier to use than others, obviously, and might have access to these screeners in different ways. So interesting. Great, thank you for sharing. And next question: how are positive screens addressed and monitored? So we talked a little bit about doing it in the moment during the visit, but if the screens are seen not in the moment, you know, how else is it communicated or addressed? And I think we kind of spoke to this a little bit in our last discussion of how, you know, we're addressing it maybe in the moment. But what about if you get it not at the same time, if you get it after the visit, or if it comes through a MyChart message or alert or something like that? Does anyone have any, what is your method that you might address this?
I probably, if it was coming to me after the fact, um, I think it would depend on what the score was, how I would address it. If it's something more immediate, trying to get the patient, you know, whether it's telehealth or an in-person appointment, having our social worker reach out to them. If it's something where it's not as immediate, just contacting them and trying to settle, you know, schedule an appointment or get them connected to resources.
Ah, perfect. And it's like you knew what my next slide was going to be because you're leading me to the screener score and appropriate care. So just as a reminder, we both have GAD-7 and PHQ-9 scores here, and what your, you know, the actions might be depending on what the score is. So yeah, if they have a GAD-7 that's less than 10, then, you know, you may not need to reach out them to at all and just make sure that you are screening on an annual basis. Whereas if they're in that medium zone, 10 to 14, this would require, you know, that, and of course over 15, depending on how high, would require a different type of communication or more urgent communication. And of course, you know, we need to decide based upon each individual situation, I think. So this is a table that's included in the clinical change package for y'all. And again, it just kind of maps the clinical actions to the screener scores. Great. And Dr. Christian, I'll hand it back over to you.
Sure. So the purpose today, as we wrap up, is to get you thinking about each stage of this workflow. This is just one example of workflow from a Boston Community Health Center, and where they've detailed from the beginning in terms of how they're collecting the information, how this is getting into the medical record, how it's being incorporated into decision-making and referrals, and then ultimately follow-up. And there's more than one way to do this. It might depend on the specifics of given patients within the clinic. So you might have different types of workflow depending on the types of patients coming in or the ways that they are being seen or characteristics of those patients. There are also different strategies to use in the same clinic over time. So perhaps you start out with a paper format that over time you would find that switching to an electronic format might be better. Or as you see information here about, for example, that patients may be more comfortable and more candid if they complete questionnaires on their own, that if there's a way to change that over to self-administered, it might both reduce staff burden and also provide more accurate data, then that might be something to try to move towards over time. Does anyone else have any questions, comments, thoughts about information presented today, either in the slides or from your colleagues as we wrap up? Okay, well, thank you for your input and for your attention.
Thank you so much, Dr. Christian and Panchal. It was very fun for me to be using the poll feature for the first time ever, and I thought it was very important to kind of see where our sites currently are with how the screenings are administered. And so I will now move us along in the interest of time. So our next presentation is about the POEM program, and it will be presented to us today by Raquel Williams. So Raquel is an Ohio licensed social worker and the Poems Education Manager. Her professional career with Mental Health America of Ohio grew from her own experience with postpartum depression and anxiety. She received peer support and communal care through the Poem Rights program. And in her current role, Raquel hopes to center equity, cultivating space that is both trauma-informed and intersectional. She looks forward to building community partnerships and seeing mental health access to care and treatment to become more available to diverse and marginalized communities. So thank you so much for joining us today, Raquel. I will switch the slides whenever you would like me to, and the floor is now yours.
Awesome. Thank you. And thank you for the introduction. Definitely just want to, echo just a thank you to you all for having me here today, and also really timely, right, to present right after Dr. Christian and Penchel, because this is right on target and in alignment with some of the work that they're doing and sharing. So yeah, without, for the sake of time, I'll get into it. POEM is a perinatal outreach and encouragement for moms support program here in Ohio. We are community-based and peer-led program. So when I mean peer-led, I mean that every individual within our staff identifies as a mom or birthing person who has survived or is in recovery, just the different language, right, around perinatal mental health condition. So I myself am a first-time mom, and I have a 2-year-old daughter. And like I mentioned, like what was shared in the intro, is that I started as a participant within the program and now am providing support and on the other side of things. So go ahead and next slide. And then we just include this in every presentation we give to just let the audience and those who we're connecting with and working with know kind of our philosophy and our stance, and that we prioritize equity in all that we do. So we do use the terms perinatal and maternal interchangeably to really describe and address that time period from pregnancy, which it could be argued what postpartum is, right? Either 12 months to 24 months postpartum. I like to just say early parenting. When you're a parent forever. So we don't have like an age range or eligibility requirement for our program, but we typically do try to connect with moms and birthing persons at pregnancy and those early days and months postpartum. So just letting you all know what I'm speaking to when I use that language. Also, when I say mom and birthing person, that's because not every person who experiences pregnancy and childbirth, including those who experience loss, not everyone identifies as a mom. So we like to acknowledge that, hold space for that, and really meet people where they're at and mirror the language that they use, right, to describe themselves. So again, not one person can be the spokesperson for all, right? Everyone has unique experiences, individual experiences. So just acknowledging that and letting you all know our frame of work. Okay, next slide. And again, just to give context, I could spend a whole presentation on this slide alone, but I won't do it today. Just to give you all kind of like why we do the work, right? Why it's important, why it matters. Of course, there's a lot of awareness and increased awareness around mental health in general, but specifically, we like to share that perinatal mental health is actually different than generalized mental health. It's specific to the time period of pregnancy and postpartum. It's very common. 1 in 5 birthing persons will experience a perinatal mental health complication. And so actually before my own pregnancy, I was not aware of this fact, this quote here, that it's the most common complication of pregnancy and childbirth, affecting 800,000 women each year in the US. And this data typically too is very heteronormative and doesn't account for people who are non-binary and same-sex relationships. It doesn't also typically account for people who are affected by pregnancy and infant loss, who are also susceptible to developing postpartum or perinatal mental health complications, so anxiety, depression, PTSD, psychosis, bipolar. It's really a spectrum and a range of different conditions, but the takeaway, I guess, for me, for you all on this slide, is that it is it impacts whole families and not just a mom and a birthing person, but children, partners. I don't know if you all knew too that like 1 in 10 men or partners can also experience mood or anxiety symptoms within the first year of parenting. So it's definitely not something that we can look away from. So this is kind of the backbone of what we do and why we do it. And then, oh, I think we had to hit it again because we had, yeah, sorry about that. And two, just giving more context to our frame of work and the model of support that we operate from. So we are a peer-based model, like I mentioned, so community-based and peer-led. So people who are doing the work are people with lived experience. And not only is that just an evidence-based model, I think the Center for Medicaid and Medicare back in 2007, right, noted the efficacy of peer-based models as a really good intervention in providing mental health treatment and access to care. But also, you know, it's the ability to meet people where they're at. To be trauma informed, right? To see someone in their environment, both past and present. It's a great cost effective way to, again, lower treatment costs and risk of hospitalizations for folks. So decreasing stigma, shame, giving you all just insight to that, right? I won't, you know, get into every little detail there, but to let you all know why we operate from a peer-based model. We really do believe that, you know, that those of us with, you know, professional license and credentials, right, we have expertise, but those who with lived experience are the experts, right? So we just want to hear them, listen to them, and follow the lead there. Next slide. This is a little bit about what POEM does. So we provide, like I said, peer support through these modes and pathways. So we have a call and text support line. We have support groups both in person and virtual. Those meet weekly. We have a calendar, and I'm sure after this, if there's resources going out, you all will have access to those links and a direct pathway to get in contact with us. But we do have a mentor program, specialized interventions. What we mean by that is, so when we connect with a mom or birthing person, really exploring what their needs are. So if they want to connect with a med management, a behavioral health specialist, anything like that, we navigate that referral. And so what is at the core of our work is being a single entry point of care. So we get the referral, the initial referral, typically from, you know, the social worker, the OBGYN, the hospital system, doulas, whoever, even self-referrals, and then we go ahead and make sure we follow up systematically on that connection, right? So getting their insurance information, finding a provider who's a network, if there's no insurance, if we need to figure out access to therapy, right, and costs and things like that. Are there pro bono counselors and therapists available? Whatever the case may be, just making sure that we're doing what we need to on our end to lift the burden and alleviate that those extra steps from the mom or birthing person, because it's overwhelming enough to be pregnant, have a baby. You know, a bunch of paperwork sometimes can feel like just too much at that time. So we just try to step in and help lift some of those to-dos and tasks and things like that. So a few different ways, right? So like I said, peer support through call, text, email as well, support groups, weekly mentor program, and then just ongoing follow-up as needed. And then this was mentioned during my introduction, right? So of POEM, we have a branch of POEM called RISE that is exclusively for and by Black moms and birthing persons. So again, the peers, so everyone who is a RISE program coordinator identifies as both Black and a mom and birthing person. So we do this because we know that Black moms and birthing persons are at higher risk for mental health conditions during pregnancy and postpartum, but less likely to receive quality care and treatment. And that's largely related to just systemic barriers, health inequities, trauma, toxic stress, stigma, cultural perceptions of parenting too, right? Looking at the reasons why someone might not share. And this actually ties well to the presentation prior to my own of thinking about screening, right, and comfortability and translation, right, of the screening tools. So do they feel comfortable to share how they're feeling? Is there fear of child services getting involved? Is there fear of law enforcement getting involved if I share that I'm not doing the best? Will my baby be taken away? And a lot of that is due to historical traumas and context and racism and systemic issues, right? So always like to note that, right, for consideration of the person and who we're engaging with, so in screening and whatnot. So that's why RISE exists. And then we have the same full spectrum of services. So I think you can move to the next slide too. Yeah, so same full spectrum services as POEM generally, but exclusively formed by Black moms and birthing persons. So the only difference here too is that we do have childcare provided at these in-person meetings right now. We hope to provide childcare at the others as well, but this is where we're at. And we also try to maintain a referral network of Black mental health providers. So if anyone on this call actually, knows of anyone and they want to connect with us and get involved and get connected with our RISE provider directory, we always welcome that and are always looking to build community partnerships there. Next slide. And so this is, I won't spend too much time on this slide either, because this is kind of a reiteration of what I've been sharing so far. Really, I just want you all to take away like who we are, what we do, and how to connect with us. So this is like the journey, I guess, of a POEM client. When we get in contact with someone, whether that be by referral or self-referral, we will follow up with them within 24 hours. We have a protocol for like how many calls or how many texts, right, will outreach before we try a different mode of communication. But then from there, we typically have weekly connections and ongoing support. Same with if we match with a mentor, then we'll check in with the mentor bi-weekly, but the mentor themselves will check in with the person weekly. So doing that to ensure that connection is made, that support is had. So what we like to emphasize is that we're following up beyond the initial connection, right? So even if at that first call we go ahead and make a referral to a mental health provider, we're still going to call or connect with that mom or birthing person a week from that to see how that connection's going, right? How are you feeling with the relationship you have with your provider? Is it a good match? Is it a good fit? Do you need additional support? Are there any community resources that I can connect you with? So it's really about the ongoing follow-up. And then we typically don't, I guess, close a relationship with a mom or birthing person until they decide that that's okay, right? If they've been reporting, an improvement in symptoms, they feel really good, they're always welcome to reach out to us and we'll let them kind of lead that process. But some moms and birthing persons within our program, have been connected for years, and maybe they're at the point where they're just attending weekly support groups, and that's okay. But it's very open, and I would say that a lot of our connections are long term. So next slide. And then this is just the outcomes to what I was just speaking to. So this was not taken from POEM itself, but this is how we model our programming. So this is from a study done in 2015 by Nancy Byatt in Massachusetts, I believe. So she had one of the very first robust programs similar to our own for moms and birthing persons, and emphasizing the ongoing follow-up and care. So what they saw was with screening alone, about 78% of those people reported that their symptoms were left untreated. So that means maybe they did the screener, they did a EPDS or a PHQ-9, maybe got some paperwork or here's a list of providers that you can connect with, but there was no follow-up after that. And what we're doing and where we're flipping that statistic a bit is saying they've been screened, they've received that referral, but they're also getting the, I guess, warm handoff or the ongoing connection and care. And that's made all the difference. So a way to break down this slide of that's just numbers, right? So go ahead, next slide. And then last piece, and what I'll kind of close with, is just a growth that we've experienced in POEM. So in addition to that direct peer support, something recently that we've expanded to be able to provide is POEM statewide. And this is actually where the heart of my work is right now. So myself and my colleague, Becca Alexander, pretty much make up our POEM statewide team right now. We're a small group, but we have grown to see, right? So some of those cultural barriers, the inequities that we've noticed, even issues with screening and how to, right? We're focused on providing education, awareness, and movement building around perinatal mental health. So some of our services and projects are developing a culturally responsive screening protocol. So by protocol, meaning like a process on how to screen, right, for Black moms and birthing persons, Latinx moms and birthing persons when it's not maybe as easily translated or the language doesn't match or fully capture that person's experience. So we're working on that. We have a public awareness initiative launching and a campaign by the end of this summer, but yeah, probably end of the summer, early fall. And then we also have a task force in the works right now that our first meeting was in February. We're continuing to meet quarterly and then but like staying connected monthly. So those resources too will be shared if you all are interested in connecting in any way around that. But also you can contact me directly. I'm happy to answer any questions and share more about these projects in detail or in depth if that's of interest. And then this is the task force, so too. So we just developed 5 strategic areas at this last meeting that we had in May. So right now we're focused on, research and data, public awareness, screening and identification, treatment and support, and then policy and regulation. And what we'll see too is that there's going to be a lot of cross between these strategic areas, but the goal is to develop some action teams, my goodness, sorry, within each area that will have its own projects and objectives from there. So that's where we're at right now. The action teams, we're just gathering interest. So if you want to, join, now's the perfect time. Thank you.
Thank you so much, Raquel. Are there any questions for Raquel while we have her on the meeting? Well, thank you so much for joining us today. It's always so powerful to, I guess, learn about a program with someone who is very passionate about that program. I think you really showed that passion through. So I was very, very interested in everything that you talked today. This presentation, along with everything else we've discussed today, will be sent out along with a recording of today's AP call. So you should all be able to have Raquel's information to be able to provide her with any questions you may have. And yes, so thank you so much, Raquel, for joining us today.
Thank you for having me. And if it's all right with y'all, I am gonna hop off because, like I said, transparency. I'm my mom or my daughter's home. I'm a mom, so my daughter's home, and I have to get her down for a nap. So, like, I can hear her losing it downstairs. So,
Yes, thank you so much for your time. Bye-bye. Right, so then I am moving us along to the quality improvement portion of our presentation. Wendy, our co-PM, is going to take over this presentation.
Hi, everyone. This is Wendy Grosnick, and I am the Quality Improvement Coach for the Focus on Me project. And I wanted to run a few slides here with you today. So last month, we focused on the plan and do portions of the PDSA. And now I'd like to go ahead and focus on the study and act portion. So on the next slide, we're going to go ahead and I believe this is your last poll of the day. We don't typically have that many, but we want to go ahead and think about your PDSA style. Are you a big planner? Do you like to get everything down on paper before you jump in and do anything? Are you a data-driven person? You like to study the results to see how you can improve? Go ahead and log your votes there? Okay, so I see planner and doer come out on the top of this poll, and that seems to be kind of consistent with what we've seen in most of our quality improvement projects. Um, but I just want to let everyone know that this is a whole team effort. Just because you're a planner doesn't mean you don't need the doers involved. These PDSAs aren't run in silos. They should be actually, you should be running them in the environment in which the PDSA would normally take place, and with all the team members that would typically be involved or impacted from the intervention. So think small as you're running your first PDSA. They should be done on a very small scale, like potentially one provider, one afternoon. Go ahead and flip to the next slide, please. And this is the PDSA activity worksheet. And this is where once you identify your plan and you've done your plan, you're going to go ahead and start documenting the results here. And then start to think about, did the results match your prediction? What did your data show? And like, what do you want to do based on that information? What are your next steps going to be? And so go ahead and advance the next one, please. So for the next steps, we're going to think about on the study piece of this, where you have a chance to review the data as a team. And the data can come from several different sources. It could come from the GRC. Once you begin providing us data, we'll be turning that back around into data reports and sending those back to you. However, it can be as simple as you hand collecting data or doing a chart review. And it just all depends on your intervention. So whatever you choose, just make sure that you do have data to determine if that intervention is effective. And when you're looking at the data, determine if the PDSA resulted in the change that you really wanted. Was it a success or was it a failure? Use that data to help you determine it. Failures are okay, because it's okay to figure out and fail, especially when you're doing it on a small test of change. You want those failures to come up in the early testing. That way you're able to adapt. Go ahead and flip to the next slide, because once you're able to answer that question, you'll then jump into the ACT portion. And here, you'll want to decide whether you're going to adapt, adopt, or abandon the PDSA. So if you're going to adapt the PDSA, you're going to tweak it and then retest it. And then you'll want to re-implement it with maybe a different audience or a different provider, different time of day, or any other small changes. But you want to make sure that this can happen across a variety of situations, that you're successful. Because the next option would be to adopt it. And in order to adopt it, you do want to make sure that you've ramped it up, that you've tried it in many different situations, different times of day, different environments. And then once you are ready to adopt it, make sure that you communicate it out to the entire team so everyone is ready to make those changes. Then we also have abandon, because sometimes things just go up in the air and it's a failure. And that's all right. You can abandon it and start over. Start with a fresh PDSA, not a problem. So on the next slide, we'll look at how, if you're going to go ahead and adopt, then you'll want to think about standardizing and think about your system and how you will provide sustainability in that system. Are you going to need to have a policy change, perhaps? Will EHRs need to be updated? Are you going to have to put a new screener in there, or get some mechanism to pull that data back out? What kind of staff time are you going to need for this? Are you going to need additional time for rooming? Or is it going to be somebody that's reviewing the screeners before the patients come in? So start thinking about how you can make this sustainable and how you can institutionalize this. If you've decided that you're going to adapt or abandon the PDSA, you're going to want to think about starting a PDSA-like ramp cycle. So you'll begin testing it over and over again in just multiple environments. So you're just starting back at square one, plan it out, and then start with testing it out and recording all those results. You're just going to keep that cycle over and over again until you've refined it. So as we're kind of wrapping up this part of the discussion, I just want to let you know that we'll be going through all of this in our monthly coaching calls. We'll be looking at your PDSA cycles and would like for you to send them in on occasion. And we'll be using those for the AP calls so that we can identify where there have been successes and we can share them with each other. And that's what's really going to help us create a robust learning community here. So I'll stop there and see if there are any questions. Yeah, we can't forget the celebrate part. So when you do have the win, celebrate. Okay, well, thank you very much. I think there's a few more folks out there, a few more teams that I'll need to set up coaching calls with, and I will be reaching out later on this week or early next to remind folks. Hi, Doug.
Hi.
Take it away.
Okay, thanks, Wendy. So what we want to do today is briefly go over the data submission process because we now have executed DUAs for all of the phase 2 sites. So a lot of data potentially coming in soon. We'll make sure everybody knows the process for that. So if we go to the next slide, just a general overview of kind of what the data submissions look like. We're expecting bi-weekly data due every other Monday for the regular bi-weekly data submissions, and those include all visits occurring during the previous 2-week period. But the initial data submission that we'll be getting from each site is the baseline data, which covers from January 1st, 2022 through the end of March 2023. So everybody's going to be submitting baseline data, getting caught up to present, and then beginning that bi-weekly set of data submissions. And in each file, we're anticipating visit level data with 1 row per encounter, with data for all encounters with adult female patients aged 18 to 44. And then a 1-year look back being applied for clinical values relative to the visit date. So potentially data might go back a year back prior to January 1st, 2022. Next slide, please. Okay, this is what the data submission page looks like. And you can see the link there on the right. So that is now open and available since DUAs are executed. So take note of that. But when you go to that link, you'll see a couple of quick questions just asking what site you're submitting for, what the data submission is, and then that green link there to upload the file, which we ask be a CSV or Excel file, which will get uploaded into the PHI secure portal, and then GRC can download it and process it from there. Yeah, thanks for highlighting that. Next slide. Okay, we're not going to be talking too much about the dashboard today. In future meetings, we'll do a full dashboard overview and break down all of the features. But I did just want to note that this is where ultimately the data is going to end up. This is going to be a web-based dashboard, which we'll be able to log into and see what your data look like, calculating each of the measures, looking at those in control charts or run charts, or getting demographics for your site, basically allowing you to investigate your data after it's been processed by GRC. Next slide. All right, so having talked a bit about the data submission process, we do want to take a few minutes and go over the results of our pre-work surveys, which we got 23 responses back, which is pretty good. And in terms of sort of some of the answers here, we're looking first at a question asking respondents if they know how to do a PDSA cycle. What you can see is that about 3/4 or 70% or so are answering that they're moderately confident or highly confident, but there's still a fair bit of room for improvement, and hopefully that's improved a little bit after Wendy's presentation today. All right, next slide. This next question is looking at key drivers for improvement. What you can see here is that quite a big drop has occurred in terms of the number expressing high confidence, with only 4 respondents saying that. Still a fairly large number expressing moderate confidence, but a substantial number, about 6 of that 23, saying they're not confident in this at all. So hopefully that'll improve as we get into that topic a bit more moving forward with the project. Okay, looking now at whether your team actively collects data on process changes that you test at your site? Almost everyone said yes. There was only one respondent that said no, but there were 5 that said they weren't sure. And so that perhaps suggests that maybe that data, if it is being collected, is it being used or is it being shared within the site, perhaps as well as it could be. Next slide. All right, our next couple questions ask about run charts and control charts. So this first one looking at whether the respondent knows how to interpret a run chart. What we can see here is kind of a split distribution with 9 respondents expressing high confidence, but then also 7 respondents expressing no confidence. So we'll hope to see over the course of the project is that those of you folks who haven't worked with run charts or control charts before feel much more comfortable as we move forward. Next slide. Right, here's the chart for asking the answers asking for a question about interpreting control charts. And what you can see here is that a few more people are expressing no confidence, fewer are expressing high confidence. It's a bit more evenly distributed against the across the different sort of response options there. We're looking now at a question asking whether your practice has an established process to screen patients for depression. And what we can see is that almost everyone answers that they have high confidence that this process is in place, which is good to see. Asking the same question now, but about whether there's an established process to screen patients for anxiety. And we're seeing pretty similar results, but slightly more saying that they have moderate confidence and 1 expressing that they only have slight confidence. Looking now at a question asking about an established process to follow up with patients diagnosed with depression. And, again, most saying high confidence, but several saying moderate confidence and 1 saying that they have slight confidence. And then now asking about whether your practice has an established process to follow up on patients diagnosed with anxiety. What we can see here is that we do have 8 expressing moderate confidence and 3, perhaps the highest of this group of questions, expressing slight confidence. So perhaps the least confidence in this particular question. This question we're looking at here is whether the respondent is comfortable prescribing medication for anxiety or depression for their patients. What we can see in terms of the folks who responded to the survey, majority were responding that this was not applicable to them, that they don't have a medical license that allows them to prescribe. But of those who did, the 9 of those 11 expressed high confidence, with only 2 expressing moderate confidence, which is good to see. Okay, so that was a very quick run through of the pre-work survey results. As always, if you have any questions about any of the data that you've seen, feel free to email myself or other folks on the GRC team, and be happy to answer your questions for you.
I have a quick question. Yeah. Sorry, I'm new to the process, but when you're submitting the data where you attach the CSV, can you attach multiple CSV, or are you expecting all the data be dumped into one and uploading one?
It's possible to use multiple files. So awesome. That is sometimes a thing that has to happen depending on some particularities with how the data is extracted. So that's perfectly okay. But we do prefer one file because that is easier to work with.
All right, thank you, Doug. And now I will turn it over to Melissa for check-in and next steps.
Thank you, Janella. So on the screen, you see the project life cycle, and we are in the implementation period. Next slide, please. And we wanted to call out that May is Mental Health Awareness Month. We will follow up in our follow-up email today about the call today with some resources for Mental Health Awareness Month. So we'll be sure to pass those along to you. Next slide, please. And then for our next steps for the project, so you will plan and execute your first PDSA, and Wendy will be working with our sites in coaching calls to help you with that PDSA process. So please feel free to talk that through on coaching calls or reach out if you have any questions. If you haven't already, please reach out to schedule your monthly coaching calls. And then data submission. I know that some of you are still working on your data queries, and that is totally fine. We will continue to help with that process. But once those are ready to go, you will submit baseline data, and then we will work you into our schedule for the project data. Next slide. And here is our AP call schedule so that you have these on your calendar. And please be sure to share this out with members of your clinical teams, anyone at any participating site, the more the merrier on these calls. So please feel free to share the calendar invite. Next slide. And that is all we had for today. So thank you very much for joining us. We will follow up with the slides and the recording, and please reach out if you need anything. Thank you.
Thank you, everyone. We'll stay on